is CGTN, China Global Television Network.
The COVID-19 pandemic continues to impact life around the world, and researchers are working around the clock to develop a vaccine for the virus. According to the World Economic Forum, we are seeing unprecedented cooperation between researchers, the medical industry, and regulators as they work to develop and distribute a vaccine. However, the unique nature of the pandemic means that the development of the vaccine also comes with new challenges. In addition to the urgency in which it is needed, there are various logistical considerations that must be taken into account. Well, this week on Talk Africa, we look at how close we are to having a vaccine and what are some of the challenges being addressed as the race to develop it continues. I'm Beatrice Marshall. Welcome to Talk Africa. Well, Africa has not been left behind in the search for a COVID-19 vaccine, and the first trials have begun in South Africa. A joint study between Oxford University and the University of Witwatersrand is conducting tests on 2,000 volunteers. Our correspondent Yolisa Njamela brings us more.
South Africa is spearheading the first trial in Africa to test a vaccine against the coronavirus. Wits University is collaborating with Oxford University on the trial, with funding from the South African Medical Research Council and the Bill and Melinda Gates Foundation. According to the university, some 2,000 people between the ages of 18 and 65 will be enrolled in what is widely considered to be one of the earliest and most advanced trials for a vaccine to tackle the coronavirus pandemic. 50 people living with HIV will also be included to examine the safety of the vaccine and how well they respond to it. The trial will be led by Professor Shabir Madhi, a global leader in vaccine development. Madhi has already dismissed criticism from those who say the vaccine could infect people with the virus.
The vaccine is not going to cause someone to get infected with the virus. It's not a live vaccine. As an example, polio vaccine, which is given orally, that is a live vaccine. All that it does is that it's able to actually deliver the protein that is of interest to us, to the body, to present it to the immune system. The immune system recognizes it as being foreign and mounts an immune response. It produces what we call antibodies. And those antibodies, if they're circulating, we hope that those antibodies will protect someone from developing severe disease especially. It might not protect someone from getting infected, but it will protect someone from becoming clinically ill.
Wits University says participants are intended to remain on the trial for a year. They will be given an e-diary to record any symptoms experienced for 7 days after receiving the vaccine. They will also record if they feel unwell for the following few weeks. So, how long will it take to get answers about the vaccine's efficacy?
It could be anything between 6 to 12 months, optimistically. Right? And I think that is the time horizon that people are looking at, to try to at least produce 1 billion doses in 6 to 12 months. But it all depends on whether the vaccine actually works or not.
Madhi says the first phase of the trial has already started in the United Kingdom with 4,000 participants. Second phase is the one in South Africa, and the third phase being in Brazil. The trial will also be taken to other countries such as the United States. If successful, the next level will include manufacturing facilities and global distribution. South Africa's National Health Department has already pledged its support to the trial, saying it could never have come at a better time. Yolisa Njamela for CGTN in Johannesburg, South Africa.
Well, let's now unpack how the race to develop a COVID-19 vaccine is progressing. Joining us from Geneva is Arnaud Bernard, the head of Shaping the Future of Health and Healthcare at the World Economic Forum. And from Johannesburg, Professor Shabir Madhi, he's a professor of vaccinology at the University of the Witwatersrand. Professor Madhi is also leading the COVID-19 vaccine trials in South Africa. They're both joining me via Skype. Welcome, gentlemen, to Talk Africa. Arnold, let me start off with you because you're monitoring this from Geneva, and scientists around the world are working on potential vaccines and treatments for COVID-19. Several companies are also working on antiviral drugs. Give us an understanding, though, of how far or how close we are to finding a COVID-19 vaccine.
Thank you very much, and I'm very pleased and honored to be with you today. I think it's a very, very difficult question to answer, to be honest, because we are still so early in the development of those vaccines. That said, we can certainly represent that what has happened up to now has been happening at unprecedented pace, in a way. You know, the first vaccine that got into clinical trials took 43 days to get there from the moment the DNA of the virus was sequenced, and that has never happened before at this pace. At this point in time, we have more than 140 vaccine candidates being advanced, and 13 of them are in clinical trials. So that's overall good news, but it's very early to tell if those vaccines are going to provide for full immunity, the type of antibody level they will generate, and the type of effectiveness that we will see emerge from the most promising ones.
So companies and scientists are working at an unprecedented pace to try and get a vaccine. But are there any encouraging signs or reasons to be optimistic about a vaccine at this stage, Arnold?
Well, the fact that we've got, at this point in time, 2 candidates going into phase 3 is probably very good news, because that means that at a minimum there is some degree of antibody response, and there is some proof of lack of toxicity, even though obviously more needs to be done to confirm the precise dosing of the vaccines. You know, I have to believe the communiqué of those organizations that are progressing vaccines. 2 of them, actually Moderna and AstraZeneca, are suggesting that they would deliver the first doses before the end of this year.
All right, Professor Madhi, let's look at South Africa's situation, because South Africa's first COVID vaccine trial began on June the 24th. And South Africa is the African country that is hardest hit by the virus at this stage. Tell us how that's going so far.
So much of the increased numbers that we see from South Africa is somewhat of a function of the amount of testing that's done. And even then, South Africa only tests about 5 to 10 times less than what is being done in many Northern Hemisphere countries. So even though South Africa reports the most number of cases, it doesn't mean that the rest of Africa is being spared from COVID-19. So in terms of the vaccine study itself, what we're basically doing is a phase 2 study on the vaccine that was developed at the University of Oxford, which has now been licensed out to AstraZeneca, and it's a study which we aim to both look at safety as well as to look at efficacy. Depending on the rate of transmission of the virus in the community, and at this stage in South Africa, we have not yet peaked in terms of the outbreak, it appears that we might be able to actually have a readout in terms of whether a vaccine protects against COVID-19 as early as November of this year. And unfortunately, that's just because of how rapidly the virus is actually spreading right now in South Africa.
So I just want to come back before I get onto the vaccine a bit more, Professor Madhi. I want to come back to what you've mentioned, that because South Africa is testing more than many countries in Africa or in the Northern Hemisphere, then there are a lot of numbers, reported cases in South Africa. Do you feel, though, that South Africa has reached its peak based on the number of testings that has been done, or do you feel that South Africa is starting to flatten the curve?
No, certainly not. We're nowhere close to having reached a peak, and we're certainly nowhere close to flattening the curve. In fact, right now, in all of the provinces, they're still very much on an upward trajectory. Part of the problem in terms of the type of data that we see is that because of the constraints when it comes to testing capacity, there's been changes in terms of the testing strategy. So when you start seeing some sort of declines in one province, as an example, it doesn't necessarily translate into a waning of the epidemic. It's largely speaking to changes in terms of the testing strategy. And that's what makes it really so difficult to understand exactly where we are in the outbreak in South Africa, and more so for the rest of the African continent. But what we see in terms of healthcare utilization, as well, especially in terms of hospital admissions, that has shown absolutely no sort of plateauing off in the Western Cape and the Eastern Cape, which are the two provinces that are probably a bit ahead in terms of the outbreak. In a province such as Gauteng, which is the hub, the economic hub of South Africa, we're still very much on an upward trajectory, with the doubling in terms of the number of hospitalized cases almost on a weekly basis. So we certainly haven't peaked as yet across the country, and I think in the Western Cape at least, they probably will see a peak in the next 2 to 3 weeks, and Gauteng, which is the province where I'm based, will probably be another 5 to 6 weeks before we see a peak.
And yet, Professor Mahdi, South Africa has reopened its economy. So what exactly is in place if you're talking about South Africa not yet hitting a peak, but your economy is now in place? What are you seeing?
Yeah, so I think we need to be clear that the lockdown on its own, especially in the absence of having adequate resources to be able to do testing at a very low threshold and to be able to trace down contacts of those individuals and put them into quarantine, a lockdown does not eliminate the virus. And I think that's a very naive approach, which many African countries have actually adopted without understanding what actually is required to be coupled to a lockdown to be successful in terms of slowing the rate of transmission of the virus. So the fact that we're opening up is simply driven by the reality that even during a very stringent lockdown, at an early stage of the epidemic, there was ongoing community transmission, which basically tells us, unfortunately, large parts of the population, their livelihoods were being affected by the lockdown, and consequently, they couldn't abide to what the lockdown actually required of them, coupled with we didn't have an adequate testing strategy in place. And that is the reality. So taking an approach that has worked in Europe and that is possibly working in China is not one that you can just sort of export to sub-Saharan African countries and expect it to have the same effect. I think that's a very naive approach. And in fact, if anything, what we've shown in South Africa as an example is that the indirect consequences of that approach to COVID-19, it probably will exceed the direct consequences of COVID-19.
All right. Arnold, you've heard the situation in South Africa and the race to find a vaccine perhaps by the end of the year. In terms of actually creating this vaccine, Arnold, the World Economic Forum has proposed creating a pairing mechanism for vaccine innovators, manufacturers, aimed at protecting both parties, the innovators and the manufacturers. How does the World Economic Forum propose to implement those guidelines?
And the reason why we are pushing for that mechanism is because we are worried on that the global manufacturing capacity for vaccines are limited. And they are limited, which means that if they get exclusively secured for vaccines in the very early stage of the discovery process, there is a big risk actually that they get pledged in a way to a vaccine that will not be the winning candidate at the end of the day. So what we are suggesting is that a mechanism should exist whereby some money would be provided to a number of manufacturers acting as hubs in a manufacturing network that will make investment in capacity non-specific to vaccine. I'm thinking about filling and finishing vaccines. And this would delay the pairing with the innovators' vaccines until some moments in phase 3 where the clinical efficacy of the vaccine will be demonstrated. Then the manufacturing capacity will be used for the right vaccine. So that's really the mechanism we are proposing. We have been discussing with a number of international organizations, innovators and manufacturers, including BioVac, in that call last week. And we think we can operationalize a model of that sort.
All right, Professor Shabir Mahdi and Arnold Bernard, stay with us on the program. We'll take a short break now. When we come back, we'll have more on the development of a COVID-19 vaccine. To stay tuned.
Life moves pretty fast. Ideas move at the speed of sound. Technology moves at the speed of light. If you don't filter out the noise, you might miss the details. We pay attention to the details because they matter, showing you a different perspective. See the difference.
Welcome back to Talk Africa. Still with me are Arnold Bernard and Professor Shabir Madhi. Now, before the break, we looked at how far along the development of the COVID-19 vaccine is. Let's now take a look at some of the logistical considerations as its development progresses. Arnold, given the nature, though, the rapid nature of the spread and infectiousness of COVID-19, is it safe to try and fast-track a vaccine? What are the current challenges, though, at the moment to the development of a vaccine?
Well, there are two answers to it. I think the first answer is fast-tracking doesn't necessarily mean skipping development steps. This is about running them in parallel from time to time, which has financial implications, because when you do things sequentially, actually you move to the next phase only when you're convinced that the ones before has been successful. Now, if you run phases in parallel, there is a risk that some of your investment will be lost despite, because you did not have the proof points that you should do those investments before. So there is a financial implication of doing sequencing and of doing parallel advancement of clinical phases. But the other part of the answer is the regulators are not going to be any more lenient when it comes to providing emergency use authorizations for vaccines. We've seen the FDA, it is subject to rigorous clinical trials. It is subject to clinical evidence against placebo cohorts. I think the combination of true clinical science in the delivery of the clinical roadmap and rigorous regulation for the use of vaccines are going to protect the world. And I think that's important that we don't continue to propagate that narrative about the fact that those vaccines may be unsafe, because those anti-vax lobbies are going to use that. And the last thing we want to see when the vaccine is successful is that population would reject the vaccines, because this discourse has been way too often communicated by media and organizations of all natures.
All right, Professor Madhi, let's explore that a bit in terms of propagating the narrative that the vaccines are not safe, because there have been rumors and suspicions in Africa particularly regarding the vaccine trials and their safety, and that Africans perhaps could be used as guinea pigs. Professor Madhi, how big a challenge is this as you begin trials in South Africa?
Yeah, so that narrative about, and specifically I agree with Arnold, is that we can't allow this whole narrative that these vaccines are not safe. So we need to be clear. These vaccines are never going to be used and never going to be licensed by regulatory authorities until foremost we actually establish safety and show some safety with some level of confidence, irrespective of whether the vaccine protects against COVID-19 or not. If these vaccines are not found to be safe in the clinical trials that are underway, they're simply not going to see the light of day. So I think that's the reality that we need to just accept. So now in terms of this narrative about Africans being used as guinea pigs, I think we need to be clear about this. Unlike a vaccine for TB or HIV or malaria, where you're really limited in terms of where those sort of clinical trials can be done, because they're largely diseases that affect people in low-income countries, in low-middle-income countries. When it comes to COVID-19, there simply isn't a shortage of sites globally or of scientists globally that aren't wanting to take on clinical studies to evaluate these vaccines. In fact, the narrative that Africans are being used as guinea pigs in terms of vaccine development and in terms of research generally is an incorrect narrative. The experience in high-income countries, where the majority of clinical trials are done, and many of these clinical trials are never ever done in low-income countries, is that even in high-income countries, they experience a challenge of not having enough inclusion of minority groups in their clinical trials. More than 80 to 90% of participants in high-income countries are people of Caucasian descent. So it's actually false that Africans, in particular, are being used as guinea pigs in terms of clinical trials. When it comes to the vaccine study that's being done in South Africa, as an example, it wasn't the University of Oxford that came to South Africa and asked me to participate in the study. On the contrary, it was me reaching out to them to get them to actually agree to consider having South Africa included in their clinical development program, which they did, with a proviso that I myself should actually need to raise the funds to conduct the study in South Africa. So the University of Oxford, AstraZeneca are not funding the study that's being done in South Africa. So they're not doing us any favors other than actually providing us a vaccine.
The whole question of accessibility, of course, is going to come up because this is a global problem with a global solution. Now, the World Health Organization has laid out its own rough strategic allocation when a vaccine is eventually found, looking at the global and economic issues and who exactly has been affected by the COVID-19 virus. Who should get it first when the vaccine is finally found?
You know, this is something that the Global Alliance for Vaccination and Immunization has worked with WHO to define some principles, and considering that the manufacturing capacity will be insufficient, we will have to organize prioritization, that's fair to say, and the criteria that WHO has been discussing with Gavi, the Global Alliance for Vaccination and Immunization, are about populations above the age of 65. They are to follow healthcare workers, so you would start with the 50 million healthcare workers on the planet, then go into the populations above 65-year-old, and then would go into those vulnerable populations that are affected by disease or diseases that, when combined with the coronavirus, would increase their risk of dying or getting into intensive care units. When you do all of that, obviously you don't need to vaccinate the full extent of the global population, but the problem is that the virus would still circulate globally, because you would have only covered a fraction of your population. So you have protected the most vulnerable, but the vaccine still circulates. So you can certainly expect that if in the first year you need to cover those populations, I think vaccinating pretty much everyone, considering the current capacity available, would take probably 3 years.
All right, and we are looking at it from Africa, of course, and wondering, when a vaccine is found, how accessible and affordable will it be to Africa, for instance? Arnold.
Yeah, you know, I think the mechanisms that are being discussed are mechanisms that the Global Alliance for Vaccination and Immunization has experimented and experienced and proven for the past 20 years. And I think you need to envisage that there will be a type of a tier pricing mechanism. I don't think the vaccine will be coming for free, but I think it will come from a very, very low cost to low and middle income country. And hopefully this cost will have to be the potential to be covered by official development assistance, the same way Gavi is raising funds from a number of governments to implement vaccination programs for other diseases. So I'm hopeful that with what Gavi has developed over the past 20 years, we can recycle those best practices and actually provide access. What's important is that there needs to be enough vaccines in the first place, and enough doses of vaccines that are not only reserved by companies from the north or the west.
Professor Mahdi, that is a question many on the continent are wondering, given the nature of their economies and, and many are low-income economies. Besides issues of access and costs, what challenges do you see, though, in rolling out a COVID-19 vaccine on the continent? Professor Mahdi.
Yeah, so I think I fully agree with Arnold, is that there has to be some sort of price tiering to allow vaccine access at an affordable price, both in middle-income countries as well as low-income countries. But there are other challenges that we face, including issues around differences with regard to the epidemiology of COVID-19. So as Arnold mentioned, the focus needs to be on healthcare workers and the elderly, but at the same time, it might well be that these vaccines don't perform as well in the elderly compared to people that are younger. But in the South African context, as an example, what we find because of the population demographics is that unlike in China or Europe, where we've got a much smaller percentage of the population that's under the age of 65, the major drivers of severe COVID illness, as well as the major drivers of mortality of people dying from COVID, are individuals under the age of 65 with comorbidities. In fact, the median age of people that die of COVID-19 in South Africa is closer to 55 years of age, and many of these people have got chronic underlying medical conditions. So we're going to need to contextualize again to the local setting in terms of who to prioritize. So in a South African context, we would need to be targeting people with diabetes, with hypertension, obesity, many of whom unfortunately are not even diagnosed. So if we are going the route, and I fully agree, it's unlikely that we're going to have sufficient amount of vaccine to vaccinate 2/3 of the population over the period of the next 3 to 4 years. It's essential that countries fully characterize who are the high-risk groups in their locality and actually go out searching for those high-risk groups to be able to make to be able to bring about greater efficiency in terms of vaccination.
Arnold, as we wait for a COVID-19 vaccine, in the meantime, what are the practical issues that we need to look out for?
Until the moment in time where there will not be a vaccine, and frankly speaking, there is not a cure or a treatment that is sufficiently effective at this point in time, I think we will have to do a lot of our efforts are going to be about diagnosis, and diagnosis at scale, diagnosis at a lower cost, diagnosis on point of care, diagnostics that does not require molecular diagnosis, but can be antigen testing that would be more reliable than what we have in hands today. And frankly speaking, antigen testing with lateral flow testing like pregnancy test that can be made available in cents or pennies and not euros or dollars. It has to be very, very cheap. And that's, for me, in my view, the most immediate, urgent issue. I think it's maybe underrated, but we need 500 million tests next year for low and middle income countries.
Right. Professor Mahdi, you have the final word.
Yeah, so I fully agree with Arnold. Testing is a priority in terms of rollout, but at the same time, I think what we need to appreciate, and many politicians simply don't appreciate it, even right now, is that COVID-19 is not going to be disappearing from the horizon at the end of 2020. In many countries, including African countries, we're likely to experience at least 2 to 3 waves of the outbreak, even before a vaccine becomes available. So we'll be highly pleased if we can get a vaccine that becomes available by the middle of next year. But that is not going to become available to the majority of low middle income countries into 2022, 2023. In the meantime, it's really for people to understand the need for the populace to adhere to the non-pharmaceutical interventions and for governments to basically improve on their ability to test and to basically put into place the interventions that are required to slow the rate of transmission of the virus.
Well, a very insightful discussion indeed. And that's all we have time for this week on the program. But thank you to my guests for your insights. Arnold Bernard, the head of Shaping the Future of Health and Healthcare at the World Economic Forum, and Professor Shabir Mahdi, Professor of Vaccinology at the University of the Witwatersrand. Remember, we'd love to hear your feedback through our social media handles on Facebook and Twitter. You can also catch the show on our YouTube playlist. Do keep the conversation going and tune in again next week for more Talk Africa. From me, Beatrice Marshall, and the team in Nairobi, stay safe and goodbye.